Great, we'll go ahead and start recording this, and then hopefully those that can't join us during this lunch hour can watch this later. And everyone's always welcome to contact us, email us, call our office if you have any additional questions that weren't addressed or there was something that you need more clarification on. I'm Evelyn Mok-Lin. I'm an associate professor in the Department of OBGYN here, and I'm medical director of the UCSF Center for Reproductive Health. We're going to go over a little bit about the Center for Reproductive Health, CRH, what services we offer, and then the benefits that staff have that's relatively new in terms of the infertility services coverage that that all our plans now offer. And we have Mark, who's the head of our financial team, available as well to answer any questions that you might have specific to the insurance piece and the financial piece. So in case you haven't been to our office, the Center for Reproductive Health is in Mission Bay. We're in this building right here. So we're at 499 Illinois, across from the Eye Center, right next to the Chase Center. We're in a privately owned building, so we're not actually in a UCSF building. Here's the hospital here. We lease the entire top floor of this 499 building here. CRH, we have 10 physicians, faculty physicians, and 7 nurse practitioners, and 6 fellows. We also have 2 psychologists and 2 genetic counselors that are part of our multidisciplinary team. And to make an appointment, you can do one of these 3 options. You can either call us, you can email us, or you can go to our website and schedule through the website. This is our website here, so crh.ucsf.edu. You can find everything that you would like to know. You can see our photos, the nurse practitioners, and find out more information about the services here. One thing to note is that our nurse practitioners can see you as a new patient as well, but they generally are seeing folks that are whose situation is a little bit lower complexity. So for instance, someone who may not have infertility and wants to have just sort of a consultation about trying to get pregnant soon, some same-sex couples who are doing inseminations with donor sperm, and elective fertility preservation, including egg freezing, for example. If you want to see one of the MDs, certainly if you have infertility, for the most part, the sort of algorithm would go towards the physician as a new visit, but you can also let us know if you have a preference. So as a little bit of a background, infertility is a disease, and unfortunately, it is very common. The definition of infertility is having tried to get pregnant for 12 months of actively trying, if under the age of 35, if over the age of 35, 6 or more months of actively trying to conceive. In the world, approximately 1 in 6 people have experienced infertility, so very, very common. In the United States, it's closer to 1 in 5. Physicians are also more likely to have infertility. It's closer to 1 in 4. So 1 in 4 physicians require some sort of assisted reproductive technology in order to conceive. It's a multifactorial, there's a lot of reasons for it, including delay in childbearing because of training. But even when you match other physicians to non-physicians based on age, we are more likely to have infertility, more likely to have miscarriages. Surgeons are also more likely to have high-risk pregnancies compared to non-surgeons. Besides how common it is, infertility is also important for us to acknowledge and address and advocate for, because it really has a ripple effect in terms of the impact that it can have on that person and that couple and that family. Certainly from a social perspective, mental health perspective, which is why we have 2 psychologists who just see our patients and provide support. A professional impact, there's missed days and reduced productivity at work, in part because of the mental health and social impact that it has, but also because of the sheer number of appointments that a lot of the fertility treatments require. And certainly financial, which is why we're here to talk about what the benefits are. Here are just very rough costs of IUI, which is intrauterine insemination, and IVF, which is in vitro fertilization. And unfortunately, a lot of people require more than one cycle in order to be successful. So in total, people and couples may be spending really, large sums of money in order to build the family that they're hoping to have. And it may not be feasible for everyone. At CRH, we see a spectrum in terms of reproductive health reasons for people to see us. Our most common reason is infertility. We offer diagnostic testing, and we do IUIs and IVF with genetic testing, which we'll talk a little bit more about. We also offer fertility preservation, including what we consider elective, not medically indicated, but elective egg freezing, embryo freezing, sperm freezing. And we also have very, probably the largest certainly in the area, and likely in the West Coast, in terms of oncofertility and transgender fertility preservation programs, those who see us on a more urgent basis because they're about to start their medical treatments for their next steps and need to freeze eggs, embryos, or sperm urgently. We also have what we call third-party resources, which include those who are using an egg donor, a sperm donor, or a surrogate. Now, by far, although infertility is multifactorial, the age of the egg is the #1 predictor of fertility. This is why there's generally, you'll find at the visits and in our conversations and in sort of the internet, there's a lot of focus on quote unquote female infertility. Now, we want to always acknowledge that not everyone who identifies as female has ovaries, and not everyone that has ovaries identify as female. So you'll see that I use wording such as ovarian and egg age. But that's because that is the #1 predictor of success overall. As the age of the egg increases, fertility rates go down, miscarriage rates go up, the probability of things like Down syndrome goes up. And this is not to say that the sperm doesn't matter. It certainly plays a vital role in the whole process. And as the sperm age increases, fertility rates go down as well. But the sperm biological clock is a lot more lenient and a lot longer or wider, whereas the ovarian biological clock is a lot more stringent and really confined to a shorter time period in terms of the time point during someone's reproductive lifespan that they could feasibly have a viable, healthy live birth. And that's why a lot of the emphasis will be on the person who has the ovaries. And as much as possible, whenever possible, it's always better to seek help if you're having some difficulty as soon as you can at a younger age, because the age will be the biggest determining factor. If you come to see us, sorry, I forgot to mention that we'll take questions at the end, if that's okay. So if you can put them in the chat and we'll address them at the end. If you come to see us for our new patient visit, this usually takes an hour to an hour and a half in total, just so you can budget time to come over to 499. Prior to the visit, our financial team would have queried your insurance and gotten authorization if that was necessary, or gotten you to go to your primary care or your OBGYN to put in a referral, depending on your plan. We would give you intake forms that you fill out electronically. One thing to note is that while we do use Apex, our main software is out of something called Ideas. So our office will communicate with you through the Ideas portal as opposed to through MyChart. And you'll get these intake forms that will come through Ideas. So you would log into Ideas and you would fill out your history. And if there's a partner, your partner would fill out their history as well. Your physician or NP would have reviewed all of this before your visit. But what I usually do is say, I see that you've been trying for a year and your periods are regular, but I may have some clarifying questions that I'll want to ask you during our visit. We'll talk about your goals, how many kids do you want, and in what kind of time frame. And then we will do an ultrasound if this is in person. Now, the majority of our visits for the new patient are in person, but we can do it by Zoom. And then we can always schedule the ultrasound later. So it really kind of depends on what you prefer and availability. But if we can do it in person, it's nice because then we can do the ultrasound. We can see what the follicles look like, how many follicles you have, which gives us a sense of your ovarian reserve. We can look at the uterus, and we can, at the end of the visit, draw any blood work that might be missing. Now, when you make the appointment, we'll also tell you all the labs that we want, that we're probably going to want. And if your OB/GYN can order that ahead of time, then we can review it even at the first visit, and we might be able to already just make a plan for the next step. It's totally fine if you can't, or if your primary care is reluctant to, because we can always draw it at the end of your first visit and send it off and get everything that we need. You meet with our coordinator to schedule anything else that I might want, like a semen analysis or a tubal test. And you do have the option, if you want, certainly not required, to meet with financial, or we can set up a time for them to do a consult later, and that way they have more time to figure out what your plans are and what insurance will cover. The other thing that we'll often talk about, and we have a sheet that the team can give you as well, is besides sort of medical intervention, what other things can one do? So some lifestyle recommendations. We talk a little bit about alcohol and caffeine, both of which you can have, but at sort of limited quantities. Whether there's a fertility diet, there's some data for that. Generally, low glycemic index foods to try to avoid or reduce the intake of that, sort of a more like whole foods, somewhat more plant-based diet. There's some data to support that. BMI, we know, certainly within the normal range is ideal. Too low of a BMI is not great. Too high of a BMI is also associated with lower outcomes. So we have a discussion about that and whether you should take supplements, and if so, which ones. For the most part, things like prenatal vitamins when you're actively trying to conceive are a must. Fish oil like DHA, coenzyme Q10 is an antioxidant that's been shown to improve egg quality. So we'll talk a little bit about this. We're not, as a whole, as a group, we're not very pro sort of supplements. We're very evidence-based. A lot of supplements it's a $1 billion industry, and a lot of them, they're not regulated by the FDA. They are not really well studied. They're not controlled in terms of, like, each brand could have slightly different components to it. So it's really hard to do those sorts of studies to really know what really is beneficial and what's really just an extra thing to do, an extra cost. So we generally don't recommend a lot of them, but we have a sheet of things that we have, that there's some data for, and things that we don't feel super strongly about, but probably low risk, that we can go over, that you can consider taking. And then based on all of those tests, we make a decision on what our next steps are. And that may include things like IUI, intrauterine insemination, or artificial insemination, where we give the person with the eggs, let's say, quote, female partner, the oral medication like Clomid to boost egg count. And then the partner with the sperm gives a sperm on the day of the insemination, which is timed to the day of ovulation. And we choose the best sperm and we drop it off through a catheter into the uterus. So that's an intrauterine insemination. We're taking the best sperm, putting it closer to where it needs to go, and then we're timing that and pairing that with a medication that you take orally that causes more than one egg to be ovulated. So we're boosting eggs and we're boosting sperm, and that combination of things boosts your chances of success every month by a little bit. So IUI, the benefit is it's not very involved. It's still very natural. Everything still happens in the body after we drop off the sperm. Everything else, still has to happen. It's very natural, but because of that, in part because of that, it also bumps the chances of success just by a little bit. In vitro fertilization, or IVF, is a lot more involved, where you take now injectable medications instead of oral. We extract the follicles, we add the sperm in. This is a picture of a sperm being injected into the egg. We grow the embryos in the lab in a dish, and then we choose the nicest embryo and we put it through a catheter back into the uterus. IVF generally takes 2 weeks to do, the actual stimulation part. You do these sub-Q injections on your own. We teach you how to do them, but there are a lot of appointments. So you can see on average 5 to 6 appointments during that 2-week period. They're always in the morning. Our office, CRH, opens at 7 in the morning for these appointments. We're open 7 days a week, including holidays, with the exception of 2 weeks around the end of the year. So last week of December, first week of January, we are closed. So only 2 weeks of the year that we do not do IVF during that time. We're actually still open most of those days for other appointments. But it's the only time of the year that the embryology lab gets some time off. Otherwise, we're open 7 days a week for this process. The day of the retrieval is the only day that you need off. So part of the stress of IVF, besides the financial component, which we'll get to at the end, is the logistical, especially working, depending on the nature. If you're mostly in ambulatory and you're Monday to Friday and your clinic opens at 8 versus if you're, overnight nurse and you don't get out till a certain time and you can't change that time very much. That's part of the stress. But the retrieval day is the only day that you need the day off. You have anesthesia, MAC anesthesia, so propofol. You are asleep, don't feel anything, and while you're asleep, we put an ultrasound in the vagina, and the needle goes into each ovary. So it's a minor procedure. It takes half an hour, but you do need the day off because of the anesthesia. And that day, if we're making embryos, we add the sperm. Here's sperm being injected into an egg. We grow the embryos usually to this stage called a day 5 embryo or blastocyst. And we grade the embryos based on what they look like. We have, at CRH, we have these we were actually, I think, the first clinic in the country to have these like really fancy generation 2 embryoscopes in our lab where it has like time-lapse imaging. So these embryos are in these little dishes by themselves, and then there's a camera under each well, and we have essentially time-lapse imaging videos of the embryos as they cleave individually. So we can watch the embryos develop, and the embryologist can actually rewind and see how it cleaved, how it split. They can check from home to see how the embryos are doing. And we can either pick one of the nicest embryos to transfer, or we can do something called pre-implantation genetic testing, PGT. And what that is and what PGT is we biopsy the embryo so that the teal cells are called the trophectoderm and they become the placenta. The pink cells is called the inner cell mass and they become the baby. We purposely only take a few cells from what become the placenta, and we send those cells off for testing, and we freeze the embryos. And we can test for aneuploidy, which is like an example is Down syndrome, which is an abnormal number of chromosomes. And you can see here again the age of the egg. As the age of the egg increases, the chances of having a chromosomally normal embryo drops. So we can test for chromosomes. We can find out if it's normal or not, if it has Down syndrome, if it has any extra chromosome or missing chromosome. And we can also test for specific mutation. So I have a lot of cancer patients, unfortunately. A lot of them have the BRCA1 or 2 gene. as an example, and that is something that we can test for in the embryo. So in addition to testing for general chromosomes, we can actually have the genetic company zoom in and test for a specific mutation, whether that's dominant like the cancer genes or recessive like cystic fibrosis, Tay-Sachs, there's thalassemias, there's a lot of recessive conditions. And if you and your partner carry the same gene, recessive gene, then you could either still try on your own and get testing in pregnancy, but know that there's a 25% chance of the child having the disease, or we can test the embryos ahead of time and only transfer an embryo that does not carry both copies. So that's called IVF with pre-implantation genetic testing. We can only do PGT with IVF, like we can only do any sort of testing with IVF because it's outside of your body. Whereas IUI, or if you conceive on your own, you can still get testing later, but during your pregnancy. So that is something to know, is that the technology is very powerful, but it's also not absolutely necessary, in the sense that the anything that we can test the embryos for, we can also test when you are pregnant. So it's not like we're getting information that's exclusive now that you wouldn't ultimately get later. But of course, it's a very different scenario when you are already pregnant. I just have a very quick table here that Mark's team put together that summarizes the plans that are offered to our staff. And you can see here, the main change recently was the addition of coverage for IVF. A lot of the plans previously already had coverage for IUI, insemination, and now there's most of the plans generally have roughly 2 cycles of IVF covered. But one thing to keep in mind is they are at a 50% coinsurance, so they're covered. So the out-of-pocket cost is, while less than what it would be without any benefits, it's still there's still an out-of-pocket cost, unfortunately. The other thing to note is that elective fertility preservation is not covered. So elective egg freezing, elective embryo freezing would not be covered. So these are all would have to be under the diagnosis of infertility. I'm gonna stop share, unless that's all I have for the slides, unless Mark wants me to keep this up here. But that's all I have. So I'm happy to, I don't know if Mark, if you want to say anything, or if we want to just do Q&A, what do you think?
I think before we go to Q&A, just to let everyone know that we do have a team of financial, what we call financial navigators. And so their primary role is to work with you after a treatment plan has been created with your physician to understand what out-of-pocket costs that you may be responsible for, depending on if you're going to use insurance or even comparing a self-pay rate that we offer. However, I will mention, which I will say is a positive for UC employees at this point. Utilizing your insurance coverage is more economical than doing the out-of-pocket amount. And so if you are interested in that, how the structure works is each patient would be assigned to a particular care team and physician. And then we also have a financial navigator that is part of that care team to just include a very cohesive communication between the clinical aspect as well as the financial aspect. And so that you have a team to work with and that they can just walk you through every step, answer any questions that you have, and they have direct communication either through our portal, or we have a customer service queue that you can call if you need immediate assistance, as well as email. So various forms of communication that we can explain a lot of this stuff that can be very confusing at times. In great detail, we can set up financial consults with you as well, just to make sure that you're comfortable and fully aware of, what advantages you have with using your insurance, and then of course answering any questions that you may have about it. So just one thing to add.
And then I see a question from Jessica about the age predictor fertility. That is age of the egg. That's the age of the egg that predicts. This was the slide here. Oh, sorry, you can't see. Here, this is the age of the egg. The sperm age does matter. Every decade of life, with every increase in decade of life in sperm age, fertility rates go down. But with ovarian age, an egg age, especially over 35, with every year, we can there's a measurable drop. So that's why the ovarian age is, more compacted and more stringent versus sperm has just a lot more time. It still matters, but has a lot more time. Does anybody have any other questions that we can answer for you? Go back to here as well, just to remind you of our website and the ways that you can contact us if you have any other questions. And just as a reminder that we use ideas. So it's a little bit, can be a little bit confusing because the rest of UCSF is used to using my chart. And yes, this is recorded. Okay, well, if no one has any other questions, then I'll let you finish your lunch hour. Thank you so much for joining us. Let us know. Feel free to email us. You can also email me directly if you have a specific question for me. Happy to help. Hope you have a good rest of the day.